Hey everyone, my name is Zak Holdsworth. I'm the co-founder and CEO of Hint Health, and I'm very excited today to be joined by Dr. David Cameron, who's the Chief Medical Officer of Hint Connect, and David Contorno, who's the founder of E Powered Benefits. And we're going to be talking today about a very exciting new partnership between Hint Connect and E Powered. But before we jumped into that, I just wanted to give each of these fine gentlemen an opportunity to kind of introduce themselves and their journeys. And there's actually a very interesting kind of narrative about how their journeys are kind of somewhat meeting in the middle here. Before we jump into that, though, I just want to let you know, if you have any questions, please drop them in the chat box. We're wanting to make this kind of interactive. So we'll be happy to take any questions. And also maybe I'll spend a couple of minutes talking about Hint for those of you who are not familiar with us. Hint is a company that has been focused on supporting the growth and success of the direct primary care movement for about a decade right now. We started out as a software, purely software, so the kind of membership management and billing systems that DPCs need to support their growth and successfully and efficiently managing their business. And then over time, we kind of added more and more capabilities to that platform. Recently, we launched our EMR, our clinical product, to give kind of our clinics the ability to have a single piece of software to run both the business and clinical side of their business. And recently, we also launched Hint Connect, which is what we're going to be talking about today. But Hint Connect is really about kind of creating connectivity within our ecosystem between either innovative health plans who are looking to deploy a DPC option, or employers or forward-thinking advisors like David who want to kind of implement DPC easily. So what I would like to do is kind of hand off to Dr. David Cameron, and he's going to share his journey from fee-for-service to direct primary care, and we're going to spend a bit of time there. And then we're going to hand off to David, who's going to kind of share his journey from broker to advisor. And we're going to have a little bit of a dialogue about that. Then we'll jump into the partnership. So Dr. Cameron, over to you.
Great. Yeah, Dave Cameron. I'm a family doc. I've been in practice over 20 years, and the first 10 was in fee-for-service. And it was classic fee-for-service where I had 2,500 patients, and I was seeing 25 to 30 patients a day. And my employer said that I was allowed to see 1 to 2 problems for each visit. And part of it is just so I could crank through and get as many patients through as possible. And it was not sustainable. I could not have done my whole career. I can't believe there are some of my colleagues that still are doing their whole career in that type of environment. It was not how I envisioned doing healthcare when I was in med school. It was really hard. I actually made a really hard decision. I had to make the decision to leave my patients, to leave my colleagues, and I made the leap and joined the direct primary care movement 12 years ago. And I'm so grateful that I did. Direct primary care is so fundamentally different than fee-for-service. The incentives are completely different. Instead of trying to crank through those 1 to 2 visits to get as many RVUs to increase volume, the incentive is to take care of people. It is the way that I want my family to be taken care of. And the way, and most of you all know what direct primary care is. It's a membership-based healthcare system where patients can come in as much as they want. It's unlimited. The way I refer to it is it's a small town, 1950s doc that's high tech, and that we use omni-channel, so in-person, video, text, phone visits, and we take care of the patients in the way that they want to be taken care of. And I feel like I think the best descriptor is I am their healthcare advocate. I'm their healthcare consultant. And so I've got my own practice. I'm in with 4 docs, and we are one part of Hint. So Hint Connect is a national network of direct primary care doctors, and we're one node of that. And we use Hint Health as our member services platform and billing platform. And it's really an easy way for our patients to sign up and for us to make sure that we're getting paid. It's easy. We get paid. We don't have a biller. I used to have 5 staff working just for me when I was in fee-for-service. We've got 4 doctors and 3 medical assistants, and that's it. Our overhead is so much lower because we just don't need it. We don't have all the insurance headaches. We don't have to worry about claims. We don't have a referral coordinator because we take care of that ourselves. And it is the way that I love practice. I go to work Sunday night. I used to dread going to work on Monday. I love it. I'm looking forward to Monday. So let me pass it over to you, David.
Yeah. So
Thank you,
David,
Dr.
why don't you
Keith.
share your journey?
Yeah, so I started in the insurance business at the ripe old age of 12 years old. I was telemarketing for Prudential Life Insurance, and I was really good at it. I was making $300 or $400 a week cash off the books at 12 years old. So I'm walking around the schoolyard with that brick cell phone. But about 17 years old is when I actually got into health insurance. I just turned 47, so been selling health insurance for 30 years. And, about 18 years into my career, I'm on my way to a really good, close client renewal meeting, the type of client that I would text on the weekends, like close client. And as I'm on my way there, I all of a sudden have this realization that I've done probably thousands of renewal meetings at that point in my life, and not a single one of my clients looks forward to my coming for that renewal meeting because I'm bringing in varying degrees of bad news every year. But that wasn't what changed my path. What changed my path was the meeting I'd have to do a few weeks later with their employees and tell them what's coming out of their paycheck is going up, and at the same time what's coming out of their pocket is going up. In other words, they're paying more and getting less year after year after year. And so I had a pretty large traditional insurance agency at the time, so I had access to big health insurer CEOs and CFOs and hospital CFOs and CEOs. And I would ask them, why do we keep getting worse outcomes for more money every year in our healthcare system? And their answer was the same. It's not our fault, it's their fault. Who they pointed to might have been different. But because everyone was passing the buck, I said to myself, what can I do to change this? And I realized that fundamentally, and I think this is what Dr. Cameron was really saying, how a person is paid, how they derive their own personal revenue, is set up specifically to incentivize us to do certain things. In the case of selling insurance, it's to sell as much insurance as you can. In the case of giving out healthcare, it's give out as much healthcare as you can. So a commission-based model, which is the traditional model, plus bonuses on the back end from these carriers that most employers are not aware of, are really powerful. And I get very frustrated by two groups of people, doctors and brokers, claiming that they're not influenced by the incentives of the system when they perpetually deliver the exact results that the incentives are meant to deliver, at least in aggregate. And so the first thing I did was I changed how I'm compensated. And today my fees are posted on our website. We charge a flat monthly fee, plus we typically get a piece of how much we lower costs by. So now I have an incentive to bring costs down. And as soon as I had that incentive, I then realized, although I had been in the insurance industry for almost 20 years at that point, I knew nothing about how healthcare is paid for. And at the end of the day, I'm never going to change how much money has to go into a health plan if I don't change how much money is coming out of the health. And so really, if my pivot was from brokering insurance to being a healthcare financing expert, how do we finance this and pay for this in a way that makes sense? And as soon as that opened up, I realized, well, doctors are not paid in a way that are, so how do we get doctors paid in a way? How do I find a model and embrace it? And that's, of course, what led me to direct primary care and to Hint. And so now we have rolled out hundreds and hundreds and hundreds of DPC doctors around the country embedded in our plans. And while there's some friction in building a plan without utilizing Blue Cross and Blue Shield, the one universal positive thing that we get back good feedback on is people who go to their DPC.
So I think, yeah, I mean, one of the things I just wanted to add to this is that when we started Hint, the kind of thesis we had, the vision at Hint is to, literally our vision statement is to redesign the healthcare system to enable easy access to high quality, affordable care, right? So our vision isn't, DPC centric, it's about broader healthcare transformation. And one of the kind of theses we had is that in order to do that, although there's a lot more to healthcare than just primary care, there's a fundamental axiom: if you don't transform primary care, you won't be able to transform the rest of the system around it. And so the thing I find really interesting and compelling about hearing both of your stories is how you sort of have on the one extreme a doctor coming from the fee-for-service model and kind of discovering a better way, and really focusing on, you know, providing better primary care. And then you have a broker coming from the other extreme, right? Having 20 years selling insurance and basically finding your way to DPC. And these two kind of extremes that are meeting in the middle almost. And that to me is really both just really inspiring, and also really kind of how this Hint Connect E Powered partnership is coming together, right? Because we understand kind of collectively that to transform healthcare, it's not just any one thing that needs to change. It's many things that need to change in concert. And so this partnership is really designed to help accelerate that. So maybe just quickly on the partnership. So if you're interested in learning more, there's about the partnership, you can go to epowered.hint.com. There's a bunch of information there. But the way that this is working and is essentially what's happening is, well, actually, David, why don't we start with you actually here? When you originally, you've been working with DPCs now for a number of years, and you know what is it about? And we at Hint, we power a number of DPC networks that are both partnered with Hint Connect and working alongside Hint Connect. We also have a number of independent clinics that are part of Hint Connect. And so maybe why don't we just start with you in terms of what is it that sort of brought you to the table in terms of this partnership, and what the kind of value prop is to the advisor?
Well, it is not a value prop to a commission-based advisor. So, because at the end of the day, when you have a primary care doctor and you set the plan up around that primary care doctor in a way that respects the way that that doctor is now being paid. And what I mean by that is none of our DPC docs have any prior auth, step therapy, or pre-certification requirements. If they say it's medically necessary and they're the ones who are doing it, ordering it, or prescribing it, it is not only covered with no questions asked, it's covered in full. Because if you think about that whole medical management process was designed to push back on the pressure coming from fee-for-service. And these doctors are not incentivized in that way. So I don't have to worry about them applying that pressure. But when we set up the DPC plan, we actually typically set it up alongside of a non-DPC plan, a plan where they can maintain their current doctors. But if you choose the DPC plan, it's going to have richer benefits than you've had in a really long time. It's going to have less money out of your paycheck than you've had in a really long time. But the way that we believe is best practice to set it up is to create almost like a gated HMO, to say to that patient that except in an emergency, you need to go to that DPC for everything. And only if that DPC feels clinically you need more acute care will they then refer you to a specialist, and now that specialist will be covered, because the statistic is that 82% of patients in that model never have a claim outside of the DPC. And we put the most sick, comorbid, or we encourage the sick and comorbid people to go into that DPC model. Now, for the insurance geeks out there like I am, I want to tell you fundamentally why that is so powerful. If you think about insurance that we buy, except health insurance, but every other type of insurance we buy as a business or an individual, you will probably recognize that we have one expectation of that insurance. That is to protect us from catastrophic financial loss, specifically from events that are unlikely to occur, but very severe when they do. The car accident, not the ding in the door, so on. We expect that of health insurance. We expect it to cover the heart attacks and the cancers and the strokes, but we also expect it to cover the very frequent, not severe events. And insurance as a financial vehicle doesn't function long-term when it's trying to cover both sets of events. And so by embedding DPC and creating that gated HMO model, what we've done from a purely insurance perspective is we've removed insurance completely for the very frequent, not severe events. We're paying $60 a month per person. We don't need to insure a known cost. You only need to insure the unknown. So now we've returned health insurance. Now, all this is back end. The employees don't understand this, but we've returned health insurance from a fundamental perspective back to covering only the infrequent, unlikely, severe events, which is when more acute care is necessary. And so even though the plan has the extra cost of that DPC membership, which in urban areas can be upwards of $100, $125 a person, in order to compensate for that cost, there has to be a reduction in what we refer to as downstream steerage. There has to be a reduction in those patients going to specialists, inpatient, outpatient, high-cost medications. And guess what? There is many times over the DPC membership. So the last thing I'll say on this point is, actually, I still haven't answered your question, so I'll answer that. But I never envisioned a career path in which I was going to make doctors' lives better. But that's the opportunity that brokers and consultants who might be on this call have, is to not just improve the lives of an employer, to not just improve the lives of the employees, to not just improve the lives of every single spouse and child of the employees. Instead of taking away from them, we can give them back. But you also make doctors' lives better by supporting this model, and Dr. said it. So now we have this plan design, and now we have a client with 23 offices across the country. So we need a couple of things to occur. And this is where Hint Connect has connected the dots for us. The first is people want to know, what doctors can I choose? So all the doctors that we're connected with through Hint Connect, they can go online, they can type in their zip code, and they can find the DPC doctors that we've vetted out that want to work with us that are near them. The second thing is when they pick that doctor, we need to know that they've chosen that DPC doctor. So we can set up payment to that DPC doctor. We can give that DPC doctor the right to treat that patient without pre-cert, prior auth, and step therapy, and so on. But that doctor also needs eligibility information. So when employees come and go on the plan and they choose the DPC, so Hint Connect has solved all that for us. Hint Connect allows employees to see which DPCs are working with the plan, pick it, notify the right partners that that member chose that DPC, send all the patient information to the DPC directly right into their system, and then facilitate the payment from the third-party administrator to the DPC on a monthly basis. That is what Hint solved for us, because we did it without Hint, and I literally had to make 28 phone calls, 28 different conversations, 28 different contracts, 28 different payment levels. It was a nightmare. We did it, but it was difficult. This makes that process much, much easier.
So it's fantastic. So I guess, Dr. Cameron, your perspective from the kind of physician side, what's kind of the benefit of participating in something like this, and how do you sort of think about it as a DPC clinician? Yeah,
I think one of the challenges being in a small, private, independent DPC is it's hard to win employer contracts. So I found that it's challenging because in order to attract the employer, to find the right decision maker, to understand what are the needs of that particular employer, how do you partner with brokers, advisors, and I really think the sales cycle is long. It takes a long time to be able to plant the idea. Yesterday, I actually had a CEO that came to my practice, started up as a new patient, and he loved it. He's like, how do I have this be for all of my 100 employees and their dependents? And I said, well, okay, let's hook you up to Hint Connect to see if that might be able to help. And then will their broker be amenable to this? I'm not sure. But one of the things that I think is hard is it's hard to do this well. And it's hard for small DPCs to have the resources to be able to make it happen. And that's why I think the vast majority of our patients are always retail. We're getting more and more employer patients as a movement. But still, when you think that almost half the US population gets their healthcare benefit through their employer, how are we going to really redesign healthcare unless we partner with employers? And so this is why I'm so excited that we're going to be partnering with E Powered, because we're going to be partnering with forward-thinking, progressive healthcare advisors that understand the benefit of DPC. I worked with some other, in the past, I've had an employer that was interested, and I said, okay, hey, talk to your broker. And then they had some backdoor conversations, and then it all fell apart. And they said, oops, we tried this, and DPC didn't work. I mean, you wouldn't believe how many times that's happened, and it gets really frustrating. And so I feel like the most important thing is to make sure we've got the right advisor that we're working with. And that's why I'm so excited that we're going to be working really closely with David and E Powered.
Yeah, I mean, I think one of the things that I've seen happen, David, with you is you've actually you've collaborated with DPCs who have kind of received members from the plans that you're kind of bringing to the table, and they've kind of turned around and said, "Hey, David, we've actually got an employer that is interested in kind of DPC and like rethinking their health plan, but we're not really equipped to have that conversation. Could you sit with us and kind of help go through that?" Why don't you kind of share some of the case studies from or sort of how that's panned out for you and the DPC? Because I think that's really exciting, right?
Yeah, I mean, I would say our number one source of referrals for new clients and the highest closing ratio of prospects is when the employer comes from the DPC. And typically, that the employer's, the one making the most amount of money at the company. And so they, in most cases, learned about DPC and they just paid for a membership on their own. Then they experience it. And to Dr. Cameron's point, then they're like, well, how do I bring this to my employees? And the one thing, and Dr. Cameron, you may have already realized this, but if I'm a traditional broker and I'm selling traditional Blue Cross and Blue Shield health plans, fully insured or self-funded, doesn't matter, and I bring DPC in, then I don't think the employer is going to see the savings that results, because employers can still go right to that back surgeon. Okay. So and if it does deliver savings and I'm commission based, then I'm going to be paid less money. So that's the dilemma that most brokers are in. And again, I don't think most brokers think I'm going to make this fail because I don't want to lose money, but nonetheless, it fails so they don't lose money. And so that's the challenge. And so part of why we need to educate people to do this right is to show them how, just like Dr. Cameron embraced an alternative payment model for how he gets paid, brokers can embrace a different payment model for how they get paid. And if you do that, like I did, and stupidly, I did it before I knew everything I know today, but it caused for fast learning. It's amazing how when you turn those incentives around, the outcomes change. And, Charlie Munger, the late Charlie Munger from Berkshire Hathaway, said it best: I don't need to know anything about your industry. Just show me the incentives. I'll show you the outcomes. And we have a healthcare system that benefits from inflation. Brokers make more money, carriers make more money, health systems. So it's really, if I were to put as simply as possible what it is that I do for a client, I remove those perverse incentives, and wherever possible, I turn them around. That's it. Throughout everywhere in the health plan, at the PBM level, at the doctor level, at the broker level, when you turn those incentives around, you change the outcomes. And so that, to me, is the most important piece. That's what Dr. Cameron did, and it allowed him to practice medicine the way he was trained to practice medicine, not the way the insurance company is approving or the hospital administrators are demanding. And so it's very freeing. And I feel free from the carriers, because they used to threaten me as I started down this journey to cut my contract. So when I sold my agency, I said, I'm never taking a penny in commission again, because I don't want to be in that position where they have power over me to compel me to do what they want me to do, because they never want me to do anything that's in my client's best interest.
I had a guy a couple of days ago came in and said, "Hey, I need to have a new primary care." He says, "I've got my GI doctor, I've got my cardiologist, and I've got my endocrinologist." And I said, "Well, what are they doing?" "Well, my cardiologist is writing my prescriptions for my blood pressure that's been stable for 30 years. And my GI, he's writing for my Prilosec for my heartburn. And my endocrinologist is managing my hypothyroidism that's been stable for the last 10 years. And I said, "Do you feel like you are getting the value? Do you feel like you need to go there, or would you want me to do those things? Because those are things that I do on a daily basis." And he goes, "Oh, I had no idea that primary care could do that." And I'm like, that's what I do. And so anyways, one of the things I found with direct primary care is that people are incentivized to get as many services from me, and because it's free. They come in as much as they want, and they don't have to pay a copay. There's no deductible, no co-insurance. And then as a result, they come. And one of the things that a lot of people are surprised is with the 24/7 access. I was watching the national championship game. I was working out at the gym on Monday night, watching my Huskies get crushed. That was so depressing. But one of my patients called me, and I was on the elliptical, and she was throwing up. And it was like, I don't know, 8, 9 o'clock or something like that. And it was, urgent cares were already closed. And so I said, oh yeah, no problem. So I just asked her for the phone number of her pharmacy. I called in some Zofran for her. And she texted me about an hour later and said, oh my gosh, thank you so much. I'm feeling a ton better. And it's so easy in this system to be able to divert from expensive care in the emergency room, or to really manage their chronic diseases to avoid hospitalizations that are unnecessary, and to avoid unnecessary testing, and to keep it in a the cost is already paid for by the employer, and to make sure that we're really maximizing the care that they're getting at the DPC.
Yeah. Hey, so one of the things, just harping back to your story, Dr. Cameron, just in terms of the 1950s style doctor with modern tech, right? That actually personally resonates for me, because I remember as a boy having, essentially having, my mum would call the doctor at 6 p.m. on a Friday. So it's like telemedicine, right? Or, it's like unlimited access through, virtual or whatever. We essentially had that, but you've just been layering in some slightly more sophisticated technology, but maintaining that sort of pure view of like what a doctor should be. I guess one of the questions I had for you is, when you're sort of part of Hint Connect and you're working with someone like David, what are the what's your experience in terms of caring for the patients and the expectations that are set on you as a physician?
Well, I think the expectations on me are the same. I mean, I think that we are here to treat our patients as if they are like the way that we want our family members to be cared for. So I take care of the CEO the same way I take care of the person that is getting minimum wage. There's no difference. I treat everybody the same. I give them all the best care. They all come in, and their initial visit, they get 60 minutes, and that's pretty standard for direct primary care for the first visit. And then depending on how they want to make sure they get their care through virtual or in person, or a combination of both. The nice thing about with E Powered is we got a partnership for referrals and for coordination of care, so that sometimes in fee for service especially, you have no idea the cost of things. And I used to work for a hospital system where they forced me, or loosely forced, to avoid star clause, but they really forced me to refer within the hospital system. So those MRIs would be performed at a facility where it was 3 to 4 times more expensive than the independent radiology location. I had to refer to the specialists that were in network or within that hospital system. Now I'm independent. And so we can utilize all of the resources that E Powered has, so that we can go to centers of value to make sure that we're getting the best surgeons at the lowest cost, to make sure we're going to the places where we're getting the MRI that does not have the facility fee. I remember they did a study back in New Jersey, and the cost for the same commodity would be 9 times different between one location than the other. And oftentimes it's hard to figure that out. But when you've got a good partner to be able to help you with that navigation, it can be a great partnership, so that we can make sure we're giving the best care, and then also helping our employers to make sure that their bottom line, so that they're saving money, or their costs don't keep going up every year.
Yeah, and so Dr. Cameron, I mean, one of the things that I'm really excited about that you sort of just alluded to is how, when there's a DPC that is looking after a member of one of E Powered's plans, that member actually, member actually has preferential benefits that other members may actually not have. So it gives you as the clinician the ability to essentially provide even better care to that patient, because you've got a partner that is arming you with tools that allows you to do what you otherwise may have had to go and kind of look around a little bit the system to try to figure out what's the right path here with this patient that has a high deductible plan and it's a bit complicated and whatever, right? So with this partnership, you sort of get that tool. David, I thought actually there's a question in there, and I think it ties in nicely to this, from Kevin Walker, and he's asked for kind of a graphic to compare suggested models. I don't think we have a graphic here, but I do think that maybe having you talk about kind of how the traditional model may compare in terms of cost and just kind of the offering, and maybe tie it back to this idea of these sort of preferential benefits for these DPCs, and maybe share some anecdotes of maybe cost savings or things like that. I think that'll be really helpful.
So the metric that we judge our financial performance on typically, including in our contracts with our clients and how they pay us, is tied to per employee per year cost. So basically, simple calculation, take all the money a company spent on healthcare in a 12-month period, divide that by the average number of employees on the plan. So it doesn't matter if they're single or family, we're blending them all together. According to the Kaiser Family Foundation, the average US company is spending $16,000 per employee per year. That is not including what's coming out of the employee's paycheck, and that's not including what they're paying out of their pocket on top of that. So the national average is $16,000. When we started to build the plans that we build today, before we did DPC, our plans were hovering around $7,500 to $8,500 per employee per year. However, our plans with DPC run between $3,500 and $5,500 per employee per year. So that means that our worst performing DPC client is about 65 to 70% less expensive than what the average employer is spending on healthcare. And we don't do things for the brokers that are doing things like carving out specialty. We don't carve out specialty. We don't exclude specialists. It's full ACA compliant, minimum value, minimum essential coverage. It checks all the boxes. It's a full-blown plan, but it literally costs between 50 and 70% less expensive. So it's capturing that savings, part of it, that has allowed me to continue to do the business in the model in which I'm doing it. And frankly, I make more on clients now than I did before. I'm just getting a bonus from the client when I achieve the goals the client asked us to achieve. Real quick side note to Kevin Walker's question. Part of our business model is we mentor brokers and consultants around the country. So we have some direct clients, and then we have some we call co-consultant clients. And so anyone that wants to see in real time how to sell a plan like this, how to educate an employer on a plan like this, how to build a plan like this, and how to deliver the performance, we partner with guys and gals on their first couple of groups. That's it. Once you have enough to do it on your own, go do it. We don't want a piece of that, but we'll share the revenue on the ones we work together. And I will introduce you to all of the vendors that we use, all of the partners that we use, like Hint Connect, and you'll have access to the same ecosystem that we've built.
Yeah, and one of the points I wanted to add here is one of the things that it's pretty subtle, I think, but one of the things that I think is a principle that both of our organizations share is kind of transparency in what you're doing, right? So on your side, you have very transparent prices. You've made sure your incentives are aligned. You're not kind of getting back pocket checks from people to sort of drive a certain type of behavior. And a similar thing on our side, right? With Hint Connect, we just charge a small price transparent fee that sits on top of, it's just a fixed fee per member if folks are enrolling. And it's, and everyone knows what it is. The doctors know, the client knows, and so I think there's just, and I really appreciate that about this partnership, is that it really is a kind of authentic partnership designed to provide better access and help the DPCs grow their panels and get and save money for the employer. So I think it's really awesome. Maybe one other, I guess, question I have here is for you guys: how can DPCs or employers kind of get involved with something like this? Maybe you start with Dr. Cameron. If you're a DPC, if you're interested in either getting involved in Hint Connect or figuring out how to work with an advisor like David, maybe just kind of share some of your thoughts there, and then we'll jump over on David's side.
Sure. Well, let me talk a little bit about what Hint Connect is. So we are a national network of direct primary care practices. We've got about 400 locations in 38 states so far, and we're going to keep plugging along. Our goal is to double that size by the end of 2024. And the contracts with doctors are non-exclusive, so you can be with other networks as well. And we really value autonomy. We are not going to tell you how to practice medicine. However, we do vetting. We want to make sure that people are licensed and credentialed, and we do keep track of some customer satisfaction metrics. But our whole goal is to make sure that doctors, and it's a very simple contract, and the things that we request or require to be standard DPC tenants, which are doing 24/7, same day, next day access, offering omni-channel access, and doing full scope practice, which includes for family medicine, we'll do pediatrics and adults, but we will have some internal medicine doctors and some pediatricians as well. And we want to make sure that they're doing all of the coordination of care that we'd expect. But very few, we're not demanding that they're going to practice a specific way, because there's a lot of different ways to practice medicine. There's going to be some that will be more naturally minded and some that will be more medication minded. There's always those differences. But one of the things that we look forward to is having others join the movement and join in partnership with us, particularly if there's direct primary care practices that are just starting up and want to build some volume. And we're also looking forward to having those conversations. So when employers come to the DPC, just like yesterday when I had that, if there is an employer that's interested, then we can introduce to the Hint Connect team and to E Powered, so that we can help them be able to find solutions for what they're looking for.
Yeah. And one thing, just before we move over to David, to get your perspective from the advisor side, one thing I just wanted to mention is that with Hint Connect, it really is like about creating connectivity within our ecosystem. And so that can sort of manifest itself in a few different ways. Even with David today, there's actually a few different ways that he's working with this ecosystem, right? One of them is, historically where he started, he was working with each independent DPC, right? It's a little bit of overhead there. With Hint Connect, he can work. If we have a network that we're working with that's leveraging Hint Connect, that's involved with Hint Connect, we can actually connect him directly to that entity. So we actually have something live like that today, where there's a local physician leading, and then using Hint Connect on the back end to fill the gaps where there aren't any physicians available that they don't have in their existing footprint. So there's an example of that we've got live. And then we've also got examples where, where Hint Connect is playing that role, and we're sort of playing that administration role and pushing some of those lives actually back to the local networks or the clinics in those areas. So it really is designed to be quite flexible. And I think that the principle that we're, the sort of prime directive, if you will, on our side is how can we help grow the movement and help the DPC ecosystem be as successful as possible while maintaining that autonomy, right? And so that's kind of Hint Connect is really designed to help grease the tracks there to scale in that way. So really exciting. So maybe David, if you could share some thoughts in terms of how folks can get involved either on the advisor side or with, if there's employers listening in, what that might look like.
I was in Washington, D.C. yesterday on Capitol Hill, and I was speaking with many different senators and congressmen and women to try and pass a new health transparency law that would require carriers to give the data of the plan to the plan. And the thinking behind it is that, without the data, you can't see it. And if you can't see it, you can't measure it. And if you can't measure it, you can't reduce it. But the financial incentives are not on our side here. And so what I want to speak to for the employers and the advisors, both who are on this call right now, is I want you to understand that your employees are paying for their healthcare. The employer is not paying for it because the employer only has a bucket. And when they pull money from that bucket for healthcare, they have less money in that bucket for wages or for retirement benefits. So, I get upset when hospital administrators call the carriers the payer. No, the patient is the payer. The carriers just tell us who to pay and how much to pay. If you're willing to consider leaving that world and come into a world that has transparency, which does involve kicking the carriers to the curb, and it involves getting employers to believe they can buy healthcare without a health insurer. It's a big hill to climb, I understand. The opportunity that you have as both an employer and a broker, but certainly as a broker, there is no one else that your clients employ that has the opportunity to have as big of an impact on the company financially, to have as big of an impact on every single employee and their own personal P&L. But when you start to put in things like direct primary care and do it with intention, you are actually improving the clinical care that people are getting. So who else does a company hire that can impact the company's P&L as much, the employee's P&L as much, or the outcomes of people's health? Like, these are live and die, file for bankruptcy or don't file for bankruptcy pathways. And so, and we have a coming shortage of primary care doctors in the country. We already have a shortage, it's not coming, but it's going to get worse because no one wants to go into primary care. They're not going to school for it. If we were to make DPC more ubiquitous, then it would be a lot more attractive for doctors to go into primary care. And I know everyone on this call knows that we spend more per capita on healthcare than any other nation, but we actually spend among the least as a percentage of that spend on primary care of any developed nation. And there's a reason we're spending more on specialty care. And this probably doesn't surprise anyone, but I really, truly, truly believe that the health insurance and the healthcare system have intentionally made primary care and mental health in particular such a miserable experience for the provider and such a miserable experience for the patient because it's high value care. They don't want high value care. They want acute care. So when it's hard for you to get a once a week therapist, or you have a urinary tract infection and your primary care doctor can't see you for 21 days, you go elsewhere, which is exactly what the health insurance and the healthcare system want you to do. So this is not saving your client 5% on their health insurance rates. This is fundamentally altering what they can see and what they can do as it relates to the healthcare that their employees are consuming in their families. It is fundamental, it is game changing, and it really is a win-win-win situation when you realign how you get paid.
I think we lost you.
Right, put myself on mute there. That's great, David. I mean, one of the things that I love working about you, David, is that we, as I mentioned right at the very beginning of this conversation, we kind of at Hint have this pretty, you could argue, pretty intense vision, right, to redesign the healthcare system. And when I think many companies will have a vision statement like that. But we actually are crazy enough to believe that we can actually be part of actually achieving that. And one of the things we love about working with you is that you're equally crazy in that you sort of really are trying to transform the system at a fundamental level from first principles. And my view is that this is, in order to achieve this, it is a collaboration that needs to happen between all of the sort of these emerging stakeholders that are wanting to do things differently. And direct primary care obviously is a really key important one, but also advisors, and there's a number of really innovative kind of startups that are trying to do things differently in terms and integrate DPC and other price transfer models. So it's really exciting to partner with you. I think, do either of you guys have any closing thoughts before we sign off here? Because I think it's been a great conversation, and I think we've covered a lot of ground here.
Yeah, a couple things. One, just to reiterate kind of the value prop. One of the things that's exciting when I left from fee-for-service and went to direct primary care, the customer satisfaction ratings, same doctor, but went from NPS scores of 30s to over 70. So net promoter scores, not too many people do that, but it's one of those measures that are pretty standardized, and it's nice to see that that is acknowledged with direct primary care. Quality, HEDIS measures, you can use HEDIS measures, and time again, HEDIS measures with direct primary care are we got some studies where it's like twice. It's like the HEDIS measures are twice that of fee for service. And then cost savings. It's really fun listening to you, David, about your cost savings experiences. From the Milliman study a few years ago, they would show a 13% reduction in claims, and it was a 12-month study. One of the things that we found in some of our clients, that the first year the savings were muted because patients would come and they haven't had their mammogram, they haven't had their pap smear or their colonoscopy, and so we do a lot of catch up, which is cost of the plan. But then by year 2 and 3, we've done all of those things, and there's more savings. And so that was really exciting. And I'm really glad to hear that you've been seeing those cost savings as well. And then I just think when we're talking about transforming healthcare, I think the direct primary care movement is going to be accelerated by partnerships with the brokers and the advisors and the forward-thinking teams, so that we can work together to bring this to more people. So I'm really excited. That's what gets me up in the morning, to see if we can make a better healthcare system for Americans.
Well, we have to empower the primary care physician to navigate the care in order to that to happen, which is what direct primary care does. This, again, if anyone knows me, this isn't going to surprise them, but I take a very challenger sales approach to my clients. And that's manifested itself, to my recognition at least, that the solutions are not nearly as compelling to an employer until you truly get them to understand the problems that those solutions are solving for. And one of the things that I'd like people to think about that is very different in the model I operate today versus what most employers and brokers are doing, and I'm going to use an analogy. For any of you that have children that are of driving age, or when you yourself were taught to drive, it would have been a little derelict in the parent's duty if they sat that child, the teenager, down at the coffee table, opened up the Geico policy handbook, went through all the provisions of the Geico policy, and then handed them the keys and said, go be a good driver. But isn't that what we do with health insurance every year? Don't we come in and go over the policy provisions of the Blue Cross and Blue Shield policy, and then we hand them an unlimited ID card and we say, go be a good patient? They're never going to be a good patient. I'm never going to be a car mechanic. I'm not going to be a good patient. I don't have clinical training. I need to be a clinician in order to really be a good patient. And so when we implement direct primary care, we bring the direct primary care doctor to the open enrollment meeting. Do you want a healthcare meeting? You better have someone in healthcare there. It boggles my mind that every employer almost across the country has healthcare meetings with not a single clinician at the meeting. So we bring the direct primary care doctor, and that gives me the ability to say, if you choose this DPC plan, it's not some doctor that's going to be your doctor. He or she is right here. Yeah. And it's allowed patients to maybe ask what their stance is on the COVID vaccine or LGBTQ transgender surgeries, and find a doctor that aligns with their values. It allows you to meet your doctor before they're your doctor. And once they are your doctor, as Dr. Cameron alluded to, like, you get their cell phone or text messaging platform. You get to speak to them the same day or the next day, or see them the same day or the next day. I know DPCs, we encourage, even if you're going to the emergency room, unless you're like literally having a heart attack, to call your DPC on the way to the emergency room. And we had so many times where someone fractured their arm or they had a cut, and the doctor's like, hey, it's Sunday afternoon, just meet me at my clinic. I'll stitch that up for you, no problem. Avoid an ER claim, because not only is the ER expensive, as Dr. Cameron said, but it is the lowest quality of care you're going to get is in an ER, because every person's walking in the door with every sort of disease. The doctor is acute, like, how do I protect you from dying? That's their only interest, their only training. And you're more likely to be referred into the system at a higher cost place of care than get good care in the emergency room. So we really want to avoid that. And when you have a doctor that's available to you, you're less likely to need those things. So this is so game changing to make DPC broad and easy to plug into for employer health plans, and then hopefully arm an army of brokers and consultants on how to build intelligent health plans around the DPC that not just maximizes the care and the savings for the employees and the employers, But equally as important, at least to me, is protect what the DPC has done to become a DPC. And as I mentioned earlier, we don't put any prior auth, pre-cert, or step therapy requirements on the DPCs. And so this is an opportunity. We've built out the infrastructure to make it as easy as possible. But again, I think you first have to be in an environment where at least you don't make less money as costs go down. But I also don't think we should be in an environment anymore that we make more money as costs go up. But those days they need to end soon.
Well, gentlemen, really great conversation here. For those of you who are interested in, physicians interested in getting involved with Hint Connect, you can go to the connect.hint.com/clinicians link. And those of you interested in learning more about E Powered and our partnership, or advisors or employers that wanted to get in contact with David Contorno, you can go to epowered.hint.com. And we really hope you enjoyed today's conversations. Thank you both so much for joining me here. And we're very excited about this partnership and delighted to be working with you both. So thank you so much.
Thank you.
Thanks.